I'm a nursing student, I'm here to help. We start by seeing if the patient's really dead or is just temporarily super sleepy by assessing for responsiveness and breathing. Sir, are you okay? The earlier we start doing manual compressions, the longer that time frame gets between from when they first go into cardiac arrest and when their brain starts to die. According to a study in the UK, 1 in 5 adults will witness someone collapse and be in need of CPR at some point in their life. Studies show that cardiac arrest patients who receive bystander CPR immediately have a 30% higher chance of survival than those who don't. So today I'm going to be explaining 3 different levels of saving a life. We're going to start with the untrained bystander, move on to the trained responder, and finish up with the advanced provider. I'm Nate, your friendly neighborhood paramedic, and as we're going to start more basic and become more advanced, feel free to jump around in the video as you see fit. So why does CPR matter anyway? When someone collapses, it may very well be that their heart has stopped beating, and in most situations that means we have between 4 and 6 minutes before their brain starts to die. After that, there's still a very decent chance that we can restart their heart and keep their body going, but unfortunately the things that make them them will no longer be there. Just a big old meat sack hanging out in that ventilator, really not what you want. Now if we see someone go down and immediately start pumping their heart for them, we can usually avoid that. The earlier we start doing manual compressions, the longer that time frame gets between from when they first go into cardiac arrest and when their brain starts to die. And with all of that said, there are cases of cardiac arrest resuscitations going on for several hours and the patient ultimately surviving and doing quite well. So it really just depends on what's going on. So regardless, when in doubt, just start compressions. But how, I hear you ask? Say you're frequenting your local food court and throwing back some all-American beef burgers and you look over to your left and you see an older gentleman clutch his chest and kind of take a dive to the floor. Being the good Samaritan that you are, you hop over to check on your new friend and discover that, uh-oh, he's not doing too well. We start by seeing if the patient's really dead or is just temporarily super sleepy by assessing for responsiveness and breathing. Sir, are you okay? Have you been trained how to check for a pulse at this point? Feel free to do that, but if not, just take a look at his chest, and if he hasn't been breathing for about 10 seconds, take one hand, place it over the other, take that new meat sledgehammer you just created, put it right in the center of his chest, and push hard and fast. Your options for tempo songs include Staying Alive, Another One Bites the Dust, and Baby Shark. Whatever you do, just do 1 compression per beat. Now, just make sure someone's going to get an AED and calling 911, and BAM! You completed level 1. I'm proud of you. Psst, if you made it this far, please consider liking and subscribing. It really helps me out a lot. Alright, you who are BLS CPR certified are at your local food court, and out of the corner of your eye you see level 1 guy baby sharking it up. You baseball slide in with your 2 hands and say, I'm a nursing student, I'm here to help. It's all love, y'all are great. You remember that while hands-only CPR is effective because the patient still has some oxygen floating around in their lungs and their blood, breathing for the patient is even better. You whip out your trusty pocket BVM that you have because you're just so darn prepared, and you explain to another bystander that by sealing the mask over the patient's face, positioning their airway, and squeezing this bag right here, you can push air into their lungs and essentially breathe for them. Now, every 30 seconds, it's every 30 compressions, dummy, not every 30 seconds. This guy doesn't even know what he's talking about. You just take a quick pause and take 2 breaths for the patient and then get back to CPR. Hark! The AED has arrived! Someone arrives with an automated external defibrillator that they pulled off the wall, and you are relieved because you, being a good BLS CPR certified nursing student, are well aware that a patient that is defibrillated out of a shockable rhythm early has a much better chance of survival than one who is not. You open the AED and follow its instructions, placing 1 pad on the top right of the patient's chest and the other pad in the middle of the patient's side. This roughly puts the patient's heart between the 2 pads, so it'll work. You continue to follow the voice instructions of the AED and tell everyone to stay clear of the patient as the AED analyzes the patient's cardiac rhythm. The AED then says, shock advised. And boom! You ride the lightning as if Thor, the Nordic god of thunder, was coursing through your very veins. And the patient goes, eh. It's not that cool, it's just a little bzz, it's not. But what is cool is that the paramedics have now arrived to take over the excellent care you've been providing. This is your moment, your first time leading a cardiac arrest. Your knees are weak, your arms are heavy, that turkey sandwich is sitting a little weird already, but you got this, baby paramedic Jeff. You arrive to the rare scene of a well-oiled machine taking care of your patient for you. You tell the little voice in the back of your head that's saying, can't we just scoop him up and run to the hospital? No! Because you know that you can do everything the hospital can do for that patient right here on the floor, and that gets a lot harder when you're bouncing down the road. You just saw the AED shock the patient, so you know you got about 2 minutes to get some things done before your next rhythm check. You have one of your EMT partners start an IV for medications, you have the other prepare you for intubation, and you take your pads out of your monitored defibrillator and place them on the patient. That way you can take your own look-see at the patient's heart. You remember that there are 2 shockable rhythms in cardiac arrest, ventricular tachycardia or VTach and ventricular fibrillation or VFib. You are capable of identifying them simply by quickly looking at an ECG because you're just that minimally competent. You put your pads on so they're ready to go and administer your first dose of epinephrine, commonly known as adrenaline, to give that heart a kick in the right direction and tighten up all those leaky blood vessels. Uh-oh, it's 15 seconds to rhythm check. You pre-charge your defibrillator so you can give that shock the second you need to. And a 3, 2, 1, pulse check. Nothing in PEA on the monitor, which is not shockable, so I guess we go back to compressions. You decide to intubate the patient, knowing that having a tube placed directly into the trachea will make breathing for the patient much more effective and easy. You take a peek inside the patient's mouth with your laryngoscope, place the tube through the air hole, not the food hole, note your depth, listen to lung sounds to make sure you're in the right spot, and secure that bad boy in place. Now you don't have to stop compressions to ventilate. It's pretty neat. Time flies when you're in a life and death situation, and suddenly it's time for your next pulse check. You pre-charge like a good lad, pause compressions, and would you look at that? Light 'em up, laddie! You have your Thor moment and then immediately go back to compressions just in case it didn't work. Now that we've already shocked the patient twice and he's still being stubborn, you administer the medication amiodarone. Hopefully this will chill everything out in the patient's cranky heart and just get it to do what it's supposed to. You also throw another epi in there because it probably can't hurt. Suddenly, magically it would seem, the patient's end-tidal CO2, which is the amount of CO2 they're breathing off, just tripled, and now they're opening their eyes and moving around a little bit. Sure enough, at your next pulse check, they have one. Now, the real work begins. Now that we've brought them out of cardiac arrest, we have to figure out why they were in it in the first place and keep them from doing it all over again. That's a lot of work. We're gonna take their blood pressure, heart rate, oxygen saturations, do a 12-lead ECG, look at their pupils with a pen light, listen to their lungs, put them on a ventilator, keep them sedated, and take them to the hospital. The vitals and 12-lead ECG, which is a tool for checking for heart attacks, all come back. The patient's blood pressure comes back a little bit low, so we decided that since we've already given some IV fluids, we're gonna move on to a vasopressor called Levophed. Levophed is a medication that will increase the blood pressure without putting too much workload on the heart. The ECG comes back, and it doesn't look like there are any blockages, but we can tell that the patient's electrolytes are a little messed up. The patient's EKG shows ST and QRS changes that are indicative of hyperkalemia. Maybe he was eating too many of those barium glowworms. You give calcium albuterol and sodium bicarb just for fun, all of which together more or less solve the problem for now. From here, everything kind of just chills out and we go to the hospital. The patient, Jim Bob, survives. He's discharged from the hospital a week later and goes on to send flowers every death day and names his next 3 chihuahuas after his favorite rescuers. Good job, everybody. If you enjoyed saving our new friend's life, please consider liking the video and subscribing if you haven't already. If you're interested in other content like this, you can check out the channel. There's plenty of other mediocre stuff on there at this point. Thanks for sticking around, and I'll see you in the next one. Bye-bye. Sorry, the wall. One of those is probably usable. Boom! You ride the lightning as if Thor, the Nordic god of fire, lightning, what?